Good afternoon, everyone. My name is Bianca Bridgenath, and I am the Divisional Director of Social Gerontology at the National Aging Research Institute. Welcome to our online seminar in Aging program. I would like to begin by acknowledging the traditional owners of the land on which each of us are meeting today. For me, that is the Wurundjeri Woiwurrung people. And I would also like to acknowledge the traditional owners of the land and waters across Australia. I pay my respects to elders past and present, and to all Aboriginal and Torres Strait Islander people, including members of the Stolen Generation. Before I introduce our speaker, just a little bit of housekeeping. At the conclusion of this talk, we will have some time for question and answers. If you have any questions during the talk, you can submit them through the chat function, both during the talk as well as at the very end. There will also be an opportunity to ask questions, not really in person, but at least orally, if you'd like to then put your screen on at the end as well. Today's seminar will be recorded and uploaded to our website within a few days. So do keep in mind that if you turn on your video to ask a question, your image will also be recorded in the session. Today, we're going to be hearing from Dr. Katherine Kenny. Dr. Kenny is an ARC-DECRA Senior Research Fellow in Sociology in the School of Social Sciences at the University of Sydney, where she is also the Deputy Director of the Sydney Centre for Healthy Societies. In her research, Dr. Kenny brings together cutting-edge social theory and innovative qualitative methods to develop new ways of understanding and addressing some of the key health challenges that we face as individuals, societies, and as a global community. From how we understand emerging global health threats to what we go through when we receive a diagnosis of a life-threatening illness, Katherine pays very careful attention to people's day-to-day subjective and socially situated experiences of health, illness, and care. Her aim is to develop empirically grounded and forward-thinking implications for how we can do better for our collective and societal health now and into the future. We're really excited to be having Katherine today with us. She's going to be presenting on Picturing Cancer Survivorship, a collection of photographs from the changing landscapes of survivorship study. Welcome, Katherine, and over to you.
Thank you, Bianca. And thank you also for the opportunity to present today. I feel very privileged to be able to be part of this seminar series. So I'd also like to begin by acknowledging that I live and work on the unceded lands of the Gadigal people of the Eora Nation, and that no matter where we are in Australia, and I know we're zooming in from a range of different areas, we are on what always has been and always will be Aboriginal land. I'd like to pay my deepest respect to the elders, past and present, and extend that same respect to all Aboriginal and Torres Strait Islander people and those who have and continue to care for country. So as my title suggests, today I'm going to focus on one aspect of the changing landscapes of survivorship study, which involved participant-produced photographs that were eventually made into a photographic exhibit in the gallery space of a collaborating hospital, and then were publicly displayed in a range of different forums, and most recently has been reformatted into a sort of digital exhibition that will hopefully have sort of a more or less permanent home on its own website. So let me first say something about the broader study of which it was part. So this was an ARC discovery project that I initially worked on as a postdoc. It was actually my very first postdoc, so it has quite a special place in my heart, that was focused on the shifting contemporary landscape of survivorship that we've seen probably over the last 2 decades or so, but certainly in a sort of an accelerating way in recent years. And by that, I mean the sort of reconfiguration of cancer from a disease with quite binary outcomes to one that's sort of more and more experienced as chronic. So once upon a time, cancer was like fairly acute. It proceeded through a period of treatment that either sort of failed, cancer progressed often till death, or succeeded, achieved remission, and ultimately the sort of victory of cure. But now there are new treatment regimes that are increasingly enabling people to live with cancer, even incurable cancer, for quite a long time. So rather than acute, cancer is becoming chronic. People are living with these incurable but treatable cancers for longer and longer periods of time. But these sort of what we might call terminal survivors don't necessarily fit with conventional characterizations of survivorship. So in this project, we wanted to better understand those contemporary experiences from a person-centered perspective, but also in a way that would generate a 360-degree view of the experience. So we used in-depth, semi-structured interviews, diaries, an example of which you can see there on the screen, and photo elicitation with patients, carers, and health professionals to get at some of those evolving experiences. So I'm using, the sort of academic omnipresent scare quotes, but just to signal that not everyone identifies as a patient, that these are sort of often problematic terms. Not everyone identifies as a carer. Some people see themselves as, just a wife or just a child or just a son. But to us, they're providing informal care to someone living with cancer. And the easiest designation for just the sort of purposes of my own pronunciation, if nothing else, patient and carer are the labels we'll sort of suffice with. So we wanted to understand the sort of lived experience of cancer survivorship, both not just sort of living beyond disease, but living with it in a sort of enduring kind of way, but also importantly, the sort of affective, relational, and cultural dimensions of survivorship. So people's emotional experiences, how their relationships are impacted, what expectations they feel put upon them, what kind of things they feel they can't say or can't feel or do. That sort of rich, textured, lived experience. So I think we're probably all quite familiar with these cultural expectations and the iconography that circulate around cancer. So the sort of smiling, turbaned, often white, fairly privileged breast cancer survivor, for example, is quite iconic. And these, popularly presented persona meet all the kind of normative expectations that sort of sit alongside cancer survivorship. So they go for regular screening, they eat well, exercise, approach treatment sort of indefatigably and with a positive attitude, et cetera, et cetera. And this serves some people really, really well. So one man we talked to who was in his 70s and living with lung cancer told us, the doctor cheered me up the other day when she said, "You're not a cancer sufferer, you're a cancer survivor." And he said, that changed everything straight off, just that word. So we asked, what does it mean? How does it change? And he said, well, I'm surviving. If I'd have let this go, if there hadn't been this sort of other medical complaint that led to the incidental discovery of lung cancer, if there hadn't been that, if I hadn't have had that, maybe this other problem, the cancer, might have got worse and it might have knocked me out. So I feel as though I've been lucky enough to pick up on it. So it really sort of reframed his experience for him and lent a sort of more positive weight to it. And similarly, the sort of historical shift from sufferer to survivor has done important work in bringing attention to cancer, making it more of a public concern, not just a private trouble and so on. But the cultural configuration of survivorship can still be quite prescriptive and can entail a whole host of expectations around what people should and should not feel and do. So we were interested in developing a more nuanced account, and our in-depth qualitative methods allowed us to do just that. So today I'm going to really showcase some of the sort of visual data that was generated through these participant-produced photographs. Though each photograph is accompanied by text drawn from interviews with participants. And I'll draw on some more interview data and even actually some diary data as well. So this was our research team. The first four of us here are social scientists. The other two were our collaborating oncologists. This was at the Royal Brisbane and Women's Hospital up in Brisbane. And this photo was actually taken at the launch of the photographic exhibit that was developed out of these photographs, and was actually hung in the corridor right where we're standing. So behind us there is and I don't know if some of you might be familiar with the layout of this hospital, but that's the corridor down to cancer care services. It also serves as a gallery space. So the Hospital Foundation hosts various sorts of art displays, often for sale, to sort of support, raise funds for the hospital. But we were able to use that space for the exhibit. And subsequently, it was sort of installed sort of at various public talks. It was displayed at some libraries. And as I mentioned, it's most recently been developed into a website. So you can see that the sort of the baby feet and text, that is how each of these, I think there are about 49 canvases were displayed. So in going through some of these photos here today, I'm going to highlight these particular themes as some that sort of came through quite poignantly in the photographs. So the first is the sort of imperceptibility of cancer, both in an embodied sense and in that almost cognitive sense of having to rely on quite sophisticated medical testing in order to know what's going on within one's body. The forms of dependency that living with cancer can create, the cultural imperatives towards persistence and perseverance through treatment, and ultimately sort of triumph and cure that dominate cultural sort of ideas around cancer survivorship, often sort of at any cost. The various prohibitions or cultural silences around what people feel they can't say or shouldn't feel when living with cancer. And then finally, the normalcy in experiences of living with cancer. And I kind of mean this in two ways. The first is that cancer has become such a sort of common experience. 2 out of 5, every 5 of us will be diagnosed with cancer before we turn 85. So whether we're diagnosed ourselves or we have a loved one, family member, somebody that we care about who's diagnosed with cancer, it will touch pretty much all of our lives. So there's a way in which the experience of cancer is very much the norm. It's more common than not common. But also there's sort of the normal in people's lives, sort of an acceptance of the new normal, a craving for a past normal, and so on. So let me talk about imperceptibility first. So by this, I mean the sort of uncanny embodied experience of cancer, in that it doesn't feel like anything in particular physiologically. So some participants did feel like something wasn't quite right, or that they knew something was wrong before their diagnosis. But many participants told us that they didn't feel cancer at all, and that their embodied experience was actually the embodied experience of side effects, not the embodied experience of cancer. And this was especially the case for targeted drugs that sort of follow quite different pathways to conventional treatments and can lead to all sorts of unexpected side effects that don't fit the sort of common perceptions of, chemotherapy, hair loss, nausea, and so on. So we got a lot of pictures of sort of the material, the material culture of cancer and the way that cancer was known in one's body. But back to this sense of sort of uncanny embodiment, one participant told us, it's a little bit unreal for me because I'm not feeling sick and I've never felt sick. I've never felt like there's anything particularly wrong with me. In fact, once I'd got all flushed out from the colonoscopy and started eating better, I felt pretty much better than I have in years. It's quite ridiculous, frankly, he said with a laugh. And another one said, I'm not on any medication at all, which is great. I don't even take Panadol. That's what I mean. It's a bit conflicting because here I am classed as terminal, yet I'm probably fitter and healthier than most people walking around, also with laughter. It's interesting how sort of both of these jarring experiences are resolved through that sort of moment of laughter, the discharge of that tension in the interview. So we got lots of pictures like this, MRI machines, various types of scans. And this is how people tried to sort of convey that uncanny experience of not knowing what's going on within your own body, except through these sort of very heavily mediated biomedical lenses. So this is another one who said, apart from treatment side effects, The only way that he knew he had cancer is what he was told, and no symptoms. And that this was actually the hardest aspect of living with cancer, is actually accepting it without being able to feel it per se. And this embodied unease could extend sort of well beyond the active treatment phase. So this was a radiation mask that someone had used in prior treatment. You can see the sort of the cross there is the target for brain radiation. But he had kept this mask as a sort of material reminder of the experience. And it sort of came to materialize that sort of ongoing embodied sense of precarity. So he said, I'll always be apprehensive because, you know, one day it might come back. I've been dealing with this for over 10 years. One day it might come back. So this turned the experience into sort of what this one participant characterized as a waiting game. And he meant this sort of both literally and figuratively, because he spent a lot of his time waiting for symptoms to be alleviated in this particular chair. But he also explained, actually in his written diary, he wrote, "We're playing a waiting game. Aside from the treatment side effects, the only way I know I have cancer is what I am told, as I do not have any symptoms. Probably the hardest aspect of living with cancer is accepting that I have cancer. While I've seen the results of CT and PET scans showing cancer tumors in my chest, I've had no symptoms or even discomfort. Of course, I have the medical diagnosis from the various doctors and specialists. Logic and my brain tell me that I have the dreaded disease, but I find it difficult to accept." So this sort of dissonance was one of the most challenging aspects of living with cancer for these various participants. But if imperceptibility had to do with that sort of embodied sense of precarity, dependency had to do with both how that body could be known, but also what that body could do with all the sort of ripple effects across relationships, families, and communities. And here, while I'm sort of talking about cancer and the research was on experience of cancer quite specifically, there are probably numerous parallels to aging in general, how our bodies or health status are known and viewed through the lenses of contemporary biomedicine, how we're tracking against some real or imagined norm, the potential mismatch between what we think is expected of us or expect of ourselves and our own bodily limitations, whether temporary or permanent. These were all forms of quite considerable suffering for people. And I imagine that can be the case beyond cancer as well. So this was quite a common sentiment. This is a picture of an older man's backyard and garden that was proving really difficult to maintain during and after his cancer treatment for lung cancer. So asking for help is probably the hardest thing. I guess reality hits. There's stuff I can do, there's stuff I can't do. So you do a bit of work, stop, recover, a bit of work, recover. Similarly, this participant took a picture of her floor that she had managed to mop after a long period of not having been able to do it. And that was a real sense of accomplishment. The fact that you managed to clean the house is something. And that's what she said she found really hard, not being able to do what she used to do. So there's also this sort of interesting sense of time where coming out of treatment often amounts to an attempt to move forward by circling back to a previous state. So the sort of the past, the present, and the future become entangled in this interesting kind of non-linear progression of time. Similarly, this participant said, you know, sometimes it's just the little things that make you feel good. Whether it's polishing your shoes or going to get a haircut, it just makes me feel better. It might seem simple, but they make you feel good. And also quite cutely, there's sort of a bit of a paradox of dependency here, in that it was really hard for people to rely on others, but having someone or even a dog rely on them could be a source of a lot of comfort and meaning. So it doesn't matter what's wrong with you, whether you're in a bad mood or whatever, the old dog will still wag his tail and love you. One of the sort of, I think, sort of funny things to come out of this study was that of all of the photos, I think we had over 400 photos in the end, we had over 40 pictures of dogs and we had no pictures of cats. So my sister is very much a cat person, whereas I am very much a dog person. And I feel like this study has definitively solved our sort of long-standing family argument about cats v dogs. So the theme of persistence really gets back to what I was saying earlier about the sort of conventional and often normative picture of cancer survivorship, requiring positivity, persistence, and perseverance in pursuit of a cure at almost any cost. And there's lots of literature around this, of course, the problems of late referral to palliative care for terminal patients and so on. But here I was really interested in how this is experienced by people in their day-to-day lives. So this quite nicely captures that sort of almost reflexive impetus towards #FightCancer. Although I think it's also nice to notice that there is a bit of a counter movement against this, and a sort of pushback against the sort of toxic positivity that can circulate around survivorship. And the counter movement also uses a sort of #F-word-cancer. It's just a slightly different F word than fight. But this participant sort of captures some of that sentiment of the inevitability of the pull towards treatment, that when someone tells you you've got something that's quite aggressive in you, you sit back and you think, well, whatever you've got, give it to me. I don't care what it is, just give it to me. So the pursuit of treatment sort of became just a no-brainer, not a choice, something that everyone was automatically compelled to do. And of course, that is the comfortable, the right, the best thing for lots of people to do. But in the sort of normative pressure towards that, it sets up a situation where any deviation from that course can sort of reflect back on people in a way that feels like failure. So one participant told me, I think probably looking back now, there's a lot of what ifs. Had I done things wrong? You always think, if I'd gone for the colonoscopy sooner, if I hadn't have waited, would it change where I'm at now? That's the hardest thing, is just knowing what you should be doing and knowing what you are doing just don't add up. And she goes on to say, I think that's why I've tried to keep everything as normal as I can. If I can't keep doing what I'm able to do, then is that going to make me die sooner? I think you can't give up on everything. I don't know if that's just me not being practical. So this excerpt actually comes from one of the diaries, but similarly, I think illustrates how the sort of positivity, persistence, and triumph over cancer become such a normative path that sort of not achieving remission can sort of come to feel like a failure for individuals. So in his diary, he wrote that he was, struggling to achieve his goals and felt like he was losing discipline. But he says there's great honor in fighting and by living through cancer, but it is considered failing if you die. There is no honorable way of dying from cancer. He goes on, I need to do more. But also, if you did everything that everyone thinks you should do, it's all you'd be able to do from morning to night. So the sort of relentlessness of pursuing cancer treatment was also something that sort of people reflected on quite a bit. So this is also the hallway down to cancer care services that our exhibit ultimately hung in. So there was like a nice sort of meta moment here. But this participant took a photo from the very beginning of the hall to express this, that, a day in the life, walking the mile, that there's this sort of grind to cancer treatment that people often don't talk about. It's not often seen, but it's something people really experience. That cancer treatment can become a treadmill with no exit strategy. So this same participant told us, if the day comes that the doctors say, that's it, there's nothing more we can do, I can say, great, fill out this form, I'll take out my super and go get a camper van and just go drive around Australia and just escape from it all. I don't ever tell anyone that because I don't ever talk about that sort of thing with anyone. It's one of those things that people probably get a bit upset with you and say, you're being negative, and don't think like that. So similarly, the sort of repeated experience of relentless treatment. But this idea of there are things that you can't say, you can't be negative, you can't express sort of a desire for treatment to end, moves us nicely onto the next theme that I want to discuss, which is prohibition. So by prohibition, I don't mean anything to do with temperance. What I mean is the way that some feelings, thoughts, sentiments, expressions, and actions really become prohibited by the cultural expectations around survivorship. Or put differently, there are vast cultural silences around cancer about various thoughts, feelings, and things that can't be spoken. And often people's experiences of suffering emerge from those silences. So sometimes this emerged as sort of like the commonly expressed refrain of, people don't know what to do. So although this participant felt like there was support around her, she also felt that people didn't know what to do. They didn't know what to say. They didn't know what to do. If you're sick, and especially if you've got a terminal illness, some people do not know what to say or what to do. So to harken back to the participant that sort of expressed not even being on a Panadol earlier, she went on to say, this sense of being healthy while terminal. She says, I think other people feel uncomfortable with it. They don't know what to say. They don't know what to do, I suppose. My mother particularly, and I can feel for her. I can see how she must be so upset, but she wants to pat me all the time. I'm not sick, I'm fine. Treating me like my mother would have preferred if I came home and just lay on the bed being sick, because I'm not sick. People don't know quite what to do with me. So one thing this raises that I'll come back to towards the end is that cancer is pretty much always a relational experience. It's not experienced, it's not experienced at the cellular level. It's not even experienced at the sort of individual bodily level, but it's profoundly relational and involves other people's reactions as well as embodied experiences, all the nitty-gritty between. So physical suffering was one of these other areas that was sort of kept in the shadows. Turbans were okay. Physical reminders of surgery were not. So this participant said, some things one should keep to themselves, I guess. And this scary scar was an illustration of just that. Similarly, feeling left behind, this was a view out the hospital window where someone was receiving treatment, but they felt quite imprisoned in the hospital and left behind by the world outside. Similarly, the pain that can accompany cancer and cancer treatment. This participant said, I really need to hold my tongue when people say you're looking well and things like that, or your hair's growing back or stuff like that. Especially when people say you're looking well, you feel like saying, you should have been here last week when I was on the lounge with a pillow over my head screaming because it hurt so much, but you can't. Another participant told us that she'd never discussed with anyone how hard it had been. She said, no, that's defeatist. I can't think of the word, but you can't just walk around all day going, oh, poor me. Actually, I've got this thing on my phone where I do affirmations. One of them says, to have self-pity or resentment or anger makes me an incredibly boring person. So that normative aspect is quite explicitly brought in there by marginalizing and sort of criticizing any kind of affect that is non-positive. So to move on to the last theme of normalcy, one of the ways this was expressed was by this participant who had actually reached the end of their treatment with quite good results. And the oncologist said to them, that was the Thursday, they said he used this word cured very pointedly. And this participant said, I think he was trying to really enforce to me, you're better, take it, go on with your life, go back to normal, off you go, trying to sort of destabilize that embodied precarity that I talked about earlier. And for some people, this worked really quite well. It was not a problem at all. So this participant really embraced that new normal as, not really all that different from staring mortality in the face due to old age anyhow. And she said, well, my friend and I, we totted off. We said, well, we're both dying, we'll go for a holiday. And they did. Basically, I thought, she said, well, if I'm dying, I'm dying. At least we know we're dying and we can get our things organized. And that's how she looked at it. If she needed to do something, she just did it and continued life as normal. But for other people, cancer really destabilized normal entirely. So, sorry, I've clicked on the wrong thing. So trying to sort of excise cancer from their lives entirely was what was required to get back to normal. So I thought this was a really nice image of capturing that sentiment, sort of trying to find what is often reified as a sort of stability or tranquility that preceded cancer, but trying to get back to that, however, sort of reified vision of daily life before cancer disrupted it. So these are all themes that we explore in quite depth in various other places. So this is an obnoxious long list of publications that you can find on our website if you're interested. But to try to sort of wrap up with some conclusions, looking at cancer from sort of a cultural rather than a biomedical perspective really highlights some quite different features of survivorship. So we know that 2 out of every 5 of us will be diagnosed with cancer. So whether we're diagnosed ourselves or the cancer materializes in the body of someone we love and care for, cancer will affect pretty much all of us. And so this is what I sort of mean by cancer being a relational experience, whether in relation to medical technology, the scanning devices, the PET scans, the sort of blood tests, all mediated through the interaction with the health professional. how diagnosis, prognoses, hope are all negotiated between people, often differently according to relationship. How cancer never stops at the limits of one's own body, but rather casts a complex web of relations between people, objects, emotions, and things. So if cancer affects pretty much all of us, really it's the norm, the mundane, the everyday, rather than the exceptional and the sort of moment for triumph and growth that is often characterized to be, or that people feel they need to embrace if they happen to be diagnosed with cancer. So part of our emphasis in looking at living with cancer and trying to capture some of the day-to-day materiality of what that involves for people was to capture that full range of emotions, experiences, and expressions that people have as they move through the sort of diagnosis, treatment, and possible cure, but also possible ongoing living with cancer. And one of the really important findings to emerge from this research is that a lot of the suffering sort of came out of things that you can't do, that you can't say, that people felt the tensions between their own experiences and the normative visions of what they should be doing. And so hopefully by sort of giving space to and shining light on those various cultural silences or cultural shadows, the hope is that the suffering that sort of emerges from those very places is reduced by making this part of the broader conversation. So let me leave it there, but it looks like there are some questions in the chat. So I'll just stop sharing my screen.
While you're doing that, Katherine, I might just take the opportunity to thank you for that really moving and very engaging presentation. Yes, there are questions in the chat, and I'm sure there will be others also on the screen. I know I've got a long list here as well, but we'll privilege those in the chat first. And I'll start with Mark Silva, who says, was there a chance to ask the participants what it is that they would or would have liked to have had that may or might have helped more? So help for family and friends and that sort of more wraparound support.
Oh, that's funny. There was one almost universal thing that came up in these conversations that was parking fees and transport. It's like those quite mundane logistics that mattered so much to people. So, the exorbitant fees that people pay to park at hospitals, I think anyone that's been to a hospital has experienced how sort of frighteningly expensive it can be. That really made an impact on people's lives, but also importantly, had a very differential effect according to socioeconomic status. So it disproportionately affected people who were already struggling to make ends meet. So there's not only sort of a quality of life aspect there, there's also an equity aspect that I think, above and beyond anything else, I think that was what people sort of universally came out with.
Okay, thanks. Mark, I can actually see you put your camera on. Did you have another question or a comment you wanted to make?
Oh, look, I just speak. I think it was fabulous. I haven't heard of any other wonderful project like this that actually really captures people's experiences in a way. And I love what you said about relationships. And I think, I ask another question about applies to so many other conditions that we know about. It's not just cancer. But I just wanted to know, one of the big things is, I have also a close friend who's going through all this, as many of us do here in the audience. Is there something that they've said that they could expect from friends, apart from, the parking, which is something I never even thought of, but, like from friends, what they could say? Because, you said yourself, no one knows what to do. You should ring up, you shouldn't ring up, what sort of conversations are useful, what isn't. Are there things that come out of this that are kind of helpful for friends and family to kind of take on board as a role, whether with the first circle of friends or whether the second or third circle, how we have this circle of friends we all have. Yeah.
That's a really interesting way of characterizing that with like the sort of circles of friends, because one of the things that I heard quite a lot of was that sort of quite rattling experiences of cancer can radically reconfigure who you think is in those various different circles. So I heard a lot about people sort of forging new and much closer relationships with people who, I guess, sort of stepped up, while other relationships sort of withered away. And a lot of people reflected on that being due to fear, that sort of, calling one's own mortality into question, inevitably calls the mortality of those around them into question as well. And there was so much discomfort in that a lot of people just stayed away entirely. And that sort of dropping off of contact, people like really felt quite abandoned by it. On the flip side, though, there was a way that other people felt those around them were over-involved, but often that was because of the different types of advice they were offering. So someone in the in that diary excerpt said, if you did everything that people told you should do, you'd be doing it from morning to night. If you followed every suggestion, every diet, eradicating sugar, whatever, there's just so much out there. And I think, you know, a lot of that comes from that uncanny, that unnerving sense in dealing with cancer, that it's so profoundly out of your control that being able to do something is what people really want to do. But the person who's living with cancer often doesn't want those things done to them. So I think it's that sort of relational dance of being there, being available, but on the person who is living with cancer on their terms. So I think that maintaining contact, but in that way that is not placing demands on them, sort of explicitly or implicitly, to follow advice.
Thank you, Katherine. We've got a question from Katherine, who has got a more methodological question, which is, did you supply any photo cameras to participants, or did they all use their own phones? What age groups did you involve? Did you have any older participants who might not have or use a smartphone?
Yes, yeah, those are such good questions. And it's really funny that, you know, the landscape of digital technologies has changed so quickly that it's hard to even imagine. Actually, it's hard to buy digital cameras anymore, but we did send cameras out to people. So let me back up and start with the sort of like the recruitment questions. We recruited through the Collaborating Oncology Clinic. So we got quite a wide range. And we did have patients that ranged in age from, I think our youngest patient was only like 36, but most, as you could imagine, were in that sort of 65 plus demographic. And so we had bought sort of, you know, quite simple digital cameras, and we sent them out to participants with 2 SIM cards. So the SIM card that it was preloaded with, they ended up sending back to us, and then they could keep the SIM card and have a functional camera. So that sort of stayed with them. The SIM card came back to us. And some people did choose to use their own technology. There were some people who had like fancy, DSLR cameras, and they, you know, gave us different SIM cards, but we did it all on SIM. We didn't use smartphone technology, but I feel like if we were doing that now, or if we were working with a younger demographic, I think it would be hard to ask someone to carry around an old school digital camera rather than just take photos on their phone. So I think, you know, then you get into all sorts of, you know, really important issues about data security and encryption and so on, that we've sort of worked through in different projects. But for this one, it was very, very point and click. I actually have it's not my PhD student, but a PhD student that works sort of closely with members of my team, is doing a photo elicitation project right now, but with sort of marginalized and vulnerable populations. And what they have decided to do is to buy those old disposable cameras, and then they can send back the entire disposable camera. And it seems, I mean, it feels kind of old school to develop film, but that seems to be the best way to do that right now with that population. So I think it's really a really interesting question, how best to sort of work with these types of methods, acknowledging that it has to be so sort of case by case specific. Yeah.
Thanks, Katherine. Just giving opportunity for a few more questions to come through in the chat as well. We've got one from Chow Nguyen, who actually has preempted me one of my questions, which was, did any of your participants come from a culturally and linguistically diverse background?
Yeah, that's a really good question. So in this, it was not something we actively sampled for in this project. But I think a year and a half later, we launched another project that was specifically on sort of migrant experiences of cancer care, and how sort of people's biographical histories plays in important ways into that therapeutic encounter, but not just on the part of the patient's histories, that health professionals also bring really interesting sort of backgrounds and histories to that therapeutic moment. So let me have a quick look. We published a paper on this called, in the Sociological Review, called Personhood, Belonging, Affect and Affliction. And that actually uses some of the photographs from that study that combined historical photos from people's pasts with photos in the contemporary moment. So that was a very interesting project. I probably wasn't sufficiently closely involved to say terribly much about the cultural and linguistic diversity question, but that would be a good place to look, I think.
Great, thanks for that. I've got a question also, which is, it's really struck me as you've moved through your presentation, the absolute remarkable disjuncture that there is between cancer imagery and rhetoric versus who cancer patients actually are, in terms of even the demographic that is described and portrayed. But the question I'd like you to reflect on is, has cancer been divorced from age? Unlike dementia, which is so intrinsically bound up with age, has cancer been divorced from it?
Yeah, that's such a good question. I think that part of the cleavage between cancer and age comes from fundraising attempts to raise awareness and funds for cancer research. And I think those sorts of movements, I'm thinking, especially in the US, the Susan G. Komen Foundation, for example, mobilizing that younger cohort put so much momentum and so much energy into those fundraising efforts that it's quite easy for that to become the face of cancer. There's also this sort of interesting issue of differential grievability, where what people are fighting for, doesn't resonate equally in terms of our cultural logics. So Kirsten Bell has written about this very nicely, about malignancy and motherhood, and how sort of mothers with cancer have this particular valence that other forms of cancer don't achieve. And, sort of the appeal of funding breast cancer, for example, and all of the pink ribbons and all of the sort of activity around it versus, there are no brown ribbons for colorectal cancer. Sort of this, like the sellability of different types of cancer, I think also really matters. So I think that a lot of that disjuncture between the imagery and the experience can be attributed to those fundraising efforts.
That's a very thoughtful answer. I didn't put you on the spot there. Any other questions or comments from the group? There's recently been a change in branding from the Anti-Cancer Council to Cancer Council, and also Parkinson's to Fight Parkinson's. Does this reflect the way our society is changing its views and responses? Did you want to answer that question, Katherine? Or
I mean, I do think it harkens back to these sort of dominant tropes about cancer, and sort of beyond cancer, lots of diseases, but that sort of battle mentality, the fighting for and against, fighting for cures, fighting against the disease, that has such a long history. But I do think that's at play in those sort of rebranding efforts for sure.
I might leave it there with the questions just in the interest of time, and to also give us an opportunity to look at some of the commentary in the chat about Katherine's project. Lots and lots of praise. People love the project, great narratives, images and themes from Yvonne Mills, and she's doing similar work in Queensland. Others describing this work as fabulous and incisive, great project, really resonated with their experiences, deep and interesting insight, lots of thanks. So beautiful and meaningful work, very informative, and, you know, I guess broader moral narratives about individual responsibility for health and aging, and to some extent, a place of denial of our own mortality. So I think you've really delivered a very, very thought-provoking talk, and is obviously meant a lot to a lot of people in the room. So may I all ask you to please join me in thanking Katherine with your clap reactions. Not as good as a standing applause, but you know, never mind. We'll do what we can.
Thank you so much for the opportunity to present. You know, a great organization and a great group of people to be able to talk to. So I appreciate the opportunity. Thank you.
Oh, it's our pleasure to have you. And so with that, we will close this session. And just a reminder that next month, we've got Professor Renuka Viswanathan from South Australia, who's going to be presenting on tackling frailty for healthy aging. And that will be on the 13th of June at 12 p.m. So thank you, everybody, for attending, and we will see you at our next session. Bye for now.